We have dedicated the first session to complex bifurcation lesions, and we are going to address different issues in bifurcations. We have Dr. Stoyanov here with me, Dr. Iakovou. Good morning.
Good morning. Good morning.
Thanks for
Valerie,
being
nice
with
to
us.
see you.
Thanks for being with us, and we are going to proceed. And the first lecture is going to discuss the topics of bifurcation and CTO. And I cannot find a more dedicated person to this, George Tsianos. George, please.
Thank you, Dr. Gelev. First of all, for one more time, I would like to express gratitude for the invitation. It's always a great privilege to be coming back to Sofia and participate in this wonderful meeting and meet with friends. So we heard a lot about bifurcations yesterday, and we learned a lot. So we're going to address this specific topic, what is going on with CTOs in bifurcations in the context of CTO. And there is no very much of literature because it's a very specific topic, but we have some data. What is something that it is important to stress is that it is not a very rare anatomical scenario. And by one form or the other, because not all bifurcation in the context of CTOs are the same, there are sometimes CTOs that they involve the side branch as a treatment or the main branch as a treatment, but the branch is not occluded, or the target is just one vessel occluded, or there are true bifurcations beyond the cracks or beyond bifurcation CTOs. So the procedures can have many variations. But around 1 of 3 patients with CTOs, they might involve a bifurcation in this treatment. What we know is that the CTOs, they do have a complexity, but when it's a bifurcation CTO, complexity is increasing, and that is reflected by the procedural time, which is significantly longer in bifurcation CTOs, more contrast, of course, higher number of stents. And surprisingly, in this study that this has been published, success rate was high, actually was higher compared to non-bifurcation lesions. And then that's also something that someone can criticize this study, but that's what has been reported. Of course, according to what should someone be expecting with increased complexity is the increased number of complications. That's a little bit of what we have. So when you address this kind of issue, actually one of the things that you have to show is that how these patients can be treated, or to give a glimpse of what might be involved. You see here that it's a patient that has an occluded circumflex, and the circumflex, it's obvious that has a CTO that it will be addressed as a second vessel. The right is also occluded, as you can appreciate here. CTO of the circumflex is not yet completely clear. You can see it here, a big marginal branch and a rather big distal branch for the circumflex. And septal surfing, retrograde access has been achieved for the right coronary artery. It was a blunt occlusion over there with the takeoff of a branch. The proximal cap was not clear. And you can see here that retrograde crossing happened. The guide wire entered the undergrade microcatheter. Success was achieved in this case with the right coronary, and then we proceeded to the circumflex. You can see that the marginal is provided by an epicardial collateral, as this one. It was accessed first retrogradely. The Corsair microcatheter was not able to be advanced, but the fine cross was able to follow this collateral. Antegrade access was achieved into the circumflex in a third branch existing over there, as you can appreciate here. And the second big branch was not addressed as yet. Retrograde crossing with a Gaia wire of the marginal branch. The wire is reaching the aorta. And then ping pong technique, retrograde wire of the marginal branch is entering the second guide that was placed in the left main, trapping, advancing the microcatheter, kissing balloon predilatation after positioning of the antegrade wire in the right vessel, mini crash technique, final kissing. And this is the result. It shows how the complexity can be really increased by having, in a bifurcation lesion, one vessel assessed antegradely and the other accessed retrogradely, finishing with techniques. And you see, of course, here the third branch also that it was involved in this case. So it's a little bit of a double bifurcation. All branches were rescued. Final result in this case. You can appreciate that here. You can see also a small septal rupture. Thank God it was not epicardial. Second case, this was a physician that came recently. He had a worsening angina. He was catheterized in another hospital. And he presented with this CTO. Many times when you see these, it was very easy antegrade access with a Geyer wire. And after the predilatation, you see here a small glimpse of contrast coming into the middle of the balloon. And a branch that was appearing. So the anatomy was not known. Many times when you're facing a CTO, you might come in with bifurcations. And here, a dual lumen microcatheter was used. And a wire accessed with the use of a dual lumen microcatheter. So you see not only the techniques, but specific devices necessary. Just an overview of the currently available dual lumen microcatheters. I'm not going to get into that, but they're playing a very important role into the treatment of CTOs in the context of bifurcations or bifurcations in the context of CTOs. This is the only one true dual lumen microcatheter. I'm not going to get into details of this. What happened here, one stent is placed distally. Again, mini crash technique. When you're having these true bifurcation CTO lesions, actually it's a must. Bifurcation stenting is the used or preferable technique. You don't have many options over there because it's very difficult to rescue such branches otherwise. You see the stent is placed. It's mini crashed, final kissing. An IVUS was performed in this specific case that showed, you will see the carina, a very good result. Here is the diagonal coming, the wire in the diagonal. Very nice result, even with IVUS. Another stent was necessary more distally. And you see here the final result after potting, and certainly the diagonal branch is at least as big as the LAD, and a complete revascularization was achieved in this case. I'm going to show you two more cases of increased complexity because the level of complexity that you can go in these kind of cases, it has no limits. So this is a post-cabbage patient. It happened in South Africa. You see right coronary artery, a little bit of a strange appearance over there. It's for sure the involvement of the distal anastomosis over there. A wire antegradely went nowhere. It was very obvious that this case was completely off, so no antegrade options. And you see here we start retrograde. There was a distal septal that was accessed. You get access to this vessel, then the wire wasn't going into the desired direction. You can appreciate here that is a tip injection that shows all the complexity. Here is the vein graft. You're going to see it in more detail. That goes up, and then the vessel has been retracted by the distal anastomosis. So the anatomy is something like that, and you have in red here the vein graft that had a stent over there, and then you see the complexity and the tortuosity. And just at the end of this, there is a flash CTO here. And of course, you can understand the complexity of how you address, first of all, to reach the distal cap, which is already very complex, but then to work on that. So one short attempt here, it was obvious that this is not going to work, but just showing to you how much complexity you can reach. The wire goes to the PLA. There was no any other option, second retrograde access from another more proximal collateral. So we have to access the PLA retrogradely, and this has happened. By accessing the PLA retrogradely, the tortuosity part of the PDA was actually raised. We did a typical reverse cart. We got access to the PLA. a wire was externalized and it was dilated, as you can see here, up to the point of the cracks. And then a guiding catheter extension has been used here, and he was advanced that exactly at the point of the distal cap. Then retrograde wire from the PDA is entering this guiding catheter extension, and by trapping the wire into the guiding catheter extension, we're able to advance the microcatheter of the PDA into that. Second wire was externalized, as you can appreciate here. So 2 externalized wire for each branch. So double retrograde, not single as in the previous case. We used microcatheter to exchange the wires. So over the externalized wire, you see third microcatheter coming. The wire was retracted. Antegrade wire was achieved by having 2 any more antegrade wires over the bifurcation. Standing was performed, as you can appreciate here, all the way to the proximal vessel. And then you can see the result in this bifurcation. So you have all the different scenarios from both antegrade branches crossing, from one antegrade to one retrograde. And here you see that a double retrograde was necessary for bifurcations. I'm going to finish with the third case, which is also very interesting because the complexity can go even in a higher level. And of course, and what is the higher level? You see another case that was done in Istanbul a couple of years ago. And what is the higher level? That you have an occluded bifurcation, and on top of it you have an old stent. So here you can assess the anatomy of vein graft again as the previous case. You have again a CTO and the stent is sitting on top of the CTO. So antegrade access was achieved here. There was a progress. What you can appreciate here is that it was so tough that the wire was broken, the guy a third, so it was retracted. Small part of the wire remained into the proximal RCA. This was not a problem. Again, with a knuckle, we went all the way to the distal cap. It was also subintimal. We knew it, and we wanted to be away. You can appreciate here. And then a guiding catheter extension was again introduced. And what you see here, retrograde access was performed. One retrograde didn't work. Second retrograde was necessary. And through that, we advanced the microcatheter. Here is a caravel, I think, into the PDA. You go over there, and what you see, you make a tip injection. You see that the antegrade wire is subintimal, but the wires are going again because you do have a distal anastomosis. You do have a stent, and what you're doing, you see that this wire is going into the vein graft, the old stent of the vein graft here. So what you have to do here, you're going into a level of complexity which is much higher, because here it's critically important how you puncture this stent, because actually here you don't have only to get access into the distal part of the stent, you have to get access through the right strut in order to be able to do the right job, and what to preserve also the access to the PLA, because if you puncture in this side, then by retrograde access you will lose the access to the PLA. So this is exactly what happened in this case. So you puncture the distal strut, but you have to puncture it retrogradely in order to be able to save both branches. Anyway, the right puncture was done, wire was externalized. You can appreciate here, we got into the guiding catheter extension. Not to make it, we did all the pre-dilatation part through this externalized wire, and you can appreciate here exactly what I told you. You have to puncture the right side. Wire was externalized. And then what happened here is that guiding catheter extension, right puncture of the stent, and then you take a dual lumen microcatheter that you insert here. You can see here you have, this is the front part of the dual lumen microcatheter in the direction of the PDA, and you have the second marker of the dual lumen, and the wire is going into the PLA. Access was achieved. Here you see how it happened. We had the retrograde externalized wire. Through that, we took the dual lumen, and you get access to the PLA. And then after stenting, you address with standard techniques both branches. So I showed you some of the scenario and some of the complexity. There are even higher levels than that. But the bottom line, if I have to give a message about this complex topic, is that the bifurcations lesions are frequent or not infrequent into the context of CTOs. Someone that is doing that in a high level has to be prepared for that. True bifurcation lesions, occlusion beyond the bifurcation, require special techniques and materials that everybody has to be familiar. And what you have to do is, on the top of all of these, I think that an expert treatment of lesion preparation and stenting technique should be followed as in non-CTO context to ensure optimal angiographic acute, but also long-term outcomes for these bifurcations. Thank you.
Thank you, George. That was really spectacular.
Thank you.
And I would say that these cases, you cannot see them very often.
Thank you.
Done in such proficient way. Some comments from the panelists?
Yes, Valerie. I'm always mesmerized by this kind of cases that George shows. I have to say this is the double whammy of the interventional cardiologist who deals with coronary artery disease. I think it takes a lot of expertise. It takes time in the cath lab, radiation use, and the procedure has to be itemized and customized for the patient because you have to use a lot of contrast use. You have to use a lot of contrast, and plus you have to stomach maybe the increased rate of complications, which might not be insignificant, as we know from the studies so far. So it has to be, for the dedicated experts, for CDOs to deal with this kind of cases. Personally, despite treating bifurcations all the time, there are only a couple of times that we use a double stenting technique. So maybe the approach to keep it simple has to be holds true even for the CTO. So if there is no increased, if we don't have great length in the side branch, the presumed side branch, when we deal with the CTO, then we have to stick with the simple approach even in these situations. But other than that, this presentation by George shows the complexity of this procedure, and it has to be done by the most dedicated interventionalist.
Thank you, Yanni. Congratulations for your new position and to the next step of your career also. For
Thank you,
people
George.
that don't know,
Thank
you became the director in the Onassis Heart Center.
Thank you.
Yes, we forgot. Congratulations, really.
Thank you, Valerie. Thank you.
I have a question.
Yeah.
Thank you very much for your excellent presentation. I have a question. When you detect the important side branch into the body of the CTO, what is your first step as a technique to to proceed directly to retrograde or to use dual microcatheter in terms to preserve the patency of the important side branch?
Yeah, there is no, I think, any direct answer to that because everything is related to the anatomy. So if by any means you have a glimpse of where the side branch is, as in the case we did yesterday in the circumflex, although it shows, for instance, the potential that over there antegrade access was possible, I didn't handle it in the most elegant way. I think that if I followed the suggestion of Dr. Gelev to insist more on puncturing the cap, potentially truly the cap, then it would have been not necessary to grow ADR because you will go through to true. But it was one of the cases about how you can proceed. So you can choose antegrade, you can choose retrograde, you can choose ADR, depending on the very details of the specific anatomy, and there is no rule. The main rule that someone should follow is that the more elegant the crossing, the less the material implantation will be required. And I think, for instance, yesterday, we would have finished with a single stent crossover, not very long, but it was necessary to implant 68 millimeters of stent in the direction of the distal circumflex. If the technique was more elegant and the crossing was screw to true, this was going to be 1/3 of it. So it is important at the bottom line to address, because when, with very detailed this kind of anatomy, in order to achieve and to optimize the outcomes. And there is no rule to that, in my view at least.
Yeah, thank you.
Another issue with bifurcations and CTO is that you cannot estimate the size of the branch very often, of the side branches.
Yeah.
And of course, side branch is something that you should respect, and sun branch is something, especially at the site of bifurcation, is something that makes the procedure much more difficult. And it is clear that even in the JCTO score there is a side branch, and it is changing a lot of the morphology of the cap and of the proximal cap, and you have to have a clear mind how it is changed and where is your puncture.
I didn't address as a final comment to close this presentation, that is that the imaging might play a very important role in these kind of cases. Personally, I am not good at that. That's why you don't see it. But they're very dedicated people, especially Japanese operators, that they do have great expertise to delineate anatomy with imaging or intravascular imaging, and then you can go in a very higher level of accuracy into these kind of procedures. Again, the example of the case of yesterday, IVUS might have delineated where the proximal cap is, and if someone can then go into do combined puncture of the proximal cap with direct imaging, but it comes with a price, and the price is bigger guides. So to do that, you need 8 French. We're not customized or not used to anymore in the modern day of interventional cardiology such big guidings, but someone should keep in mind that all of these things are possible, and I am pretty sure that technology and evolution of materials will address these kind of issues in a more efficient way.
Thanks, George.
Again, thank you.
Thanks. That was a great talk and discussion.
I would invite the next speaker. It's Dr. Barmpras. He will deliver his lecture. The topic will be PCI in bifurcation during acute coronary syndromes, tips and tricks. Please.
Good morning. First of all, I would like to thank the organizing committee for the opportunity to participate in this Congress. The subject of my presentation is percutaneous coronary intervention during acute coronary syndromes, tips and tricks. This presentation will give you some helpful tips and tricks of bifurcation stenting in the setting of acute coronary syndrome with case examples. But why bifurcations are so important? Bifurcation PCI accounts for approximately 15 to 20% of our daily PCI routine work. There are variations in anatomy, dynamic changes in anatomy during treatment. So we need to have an individualized approach because no 2 bifurcations are identical. The most important aspects regarding bifurcation PCI in acute coronary syndrome setting are there is no time to lose, and in ACS patients it's important to restore as fast as possible the flow. The bifurcation anatomy is unknown. The presence of thrombus with additional anatomical complexities such as severe calcification, diffuse lesions, or chronic total occlusions. Optimal pharmacotherapy based on the findings. Imaging can and should be used in ACS. Risk from imaging is smaller than the risk from suboptimal procedure, can be initiated at any point, should be interpreted cautiously. There is little clinical information on bifurcations causing acute myocardial infarction because ACS is itself a reason for patient exclusion in many randomized studies. However, there are some studies which have shed light on the field of bifurcation lesions during acute coronary syndrome. The first, by Salinas et al., studied a series of 270 patients with STEMI and bifurcation lesions causing the infarction. The results were compared with those of a control group of 2,400 patients via propensity score matching and a 5-year follow-up. The main finding of the study is that patients with and without a bifurcation lesion in STEMI showed similar short and long-term prognosis. In a second study, Choi et al. Attempted to determine the best strategy for the percutaneous treatment of bifurcation lesions causing STEMI in patients treated with primary angioplasty. The authors analyzed a series of 360 patients with STEMI, and a culprit bifurcation lesion treated with either a simple or a complex two strategy. After comparing the clinical outcomes of the two groups of patients, they concluded that the patients treated with a complex two-stent strategy had a higher rate of major events, despite successful treatment of the side branch. However, these results should be interpreted with caution because the study does not reflect current practice because of treatment with first-generation DES. The main question which should be answered is provisional stenting versus two-stent strategy for bifurcation lesions with ACS. The results of the percutaneous treatment of bifurcation lesions in the context of ACS are similar to those of randomized studies conducted outside the ACS setting. Their conclusions are in line with the usual practice of the most cath labs and the current recommendation of the European Bifurcation Club. Thus, provisional stenting technique, as in other clinical situations, should be the treatment of choice for bifurcation lesions with or without ACS. 11 randomized studies with DES comparing one or two stents approach and 8 meta-analyses showed no advantage in using systematic two stents. Stepwise provisional T is the gold standard for most bifurcation lesions, but this does not mean there will not be occasions when a two-stent strategy is required. Here an example of a provisional stenting of an LAD D1 bifurcation in the setting of an acute coronary syndrome. Both LAD and diagonal were crossed with a BMV wire, respectively. The pre-PCI OCT assessment showed a long segment fibrolipid plaque from proximal to mid-LAD. There was no stenosis in the diagonal branch. In provisional stenting OCT assessment, as we heard yesterday from Professor Stankovic, help us in predicting side branch closure, plaque burden of osteosteal proximal segment of side branch, plaque burden of main vessel at bifurcation, spiky carina, short, branching point to carina tip angle lower than 51 grade, bifurcation angle will guide in choosing provisional stenting versus two-stent strategy technique. Back to the case, after a predilatation with a 3 by 15 millimeter NC balloon at LAD, a 3 by 38 millimeter drug-eluting stent was placed in proximal LAD, sized according to the distal LAD diameter. A proximal optimization technique was proceeded with a 4 by 8 millimeter NC balloon. Post-dilatation of the mid and distal stent part with a 3.5 by 12 millimeter non-compliant balloon. A distal LAD stenting followed with a 3 by 12 millimeter DES due to a distal edge dissection. The jailed wire was retracted, and a new BMV wire have done a distal crossing of the diagonal branch. Kissing balloon inflation, report, post-OCT assessment showed optimal stent apposition and expansion, and here you can see an optimal final angio result. I would like, image-guided bifurcation PCI is useful in determining strategy, plaque assessment, and sizing of balloons and stent. Post-PCI optimization helps in identifying and rectifying predictors of DES outcome, medial dissections, apposition, and expansion. The EBC principles of treatment for bifurcations: keep it simple and safe, limit the number of stents, respect the original bifurcation anatomy, and try to reproduce it. Aim for well-apposed and well-expanded stents with limited overlap. The elective treatment of bifurcated lesions with complex anatomy and diffuse atherosclerotic involvement of both the main vessel and the side branch usually requires a two-stent approach. The EBC encourages operators to keep things simple where possible, but when a two-stent strategy is used, this should be done in a provisional stepwise approach to the lesion, finalizing the procedure using T TAP or Eculot technique. For operators with appropriate experience, DK crash is a valuable option for complex left main bifurcation lesions. It's known how to perform provisional standing. It's very important to say that main vessel standing should be done according to the distal reference diameter. And I would like to continue with a case illustrating treatment of a distal left main LAD bifurcation lesion classified as Medina type 110 in a patient presenting with anterior STEMI. The patient was a 67-year-old man who was urgently transferred from a healthcare center to a hospital due to an anterior STEMI. At presentation, ECG showed poor airway progression and ST elevation in anterior chest walls. Echo showed severe LAD territory hypokinesia with preserved thickness, but low EF of 25%. Urgent coronary angiography revealed, as you can see, a distal left main lesion classified as Medina 110 with 95% distal left main stenosis and subsequent 95% ostial and proximal LAD stenosis with impaired flow in distal LAD. There was also a 50% ostial L6 stenosis. The strategy plan: left main was engaged with a 7 French EBU 3.5 guide catheter. The angiographic finding was highly suspicious for thrombus formation, therefore manual aspiration was performed with an export AP aspiration catheter while the patient received concomitantly intravenous tirofiban. We decided to proceed PCI of the left main LAD stenosis using the provisional stent strategy. Our aim was to keep it safe and simple, and only in case of unsatisfactory result of the side branch, a two-stent strategy will be required. The PCI was under cardiosurgical backup and mechanical support of circulation with an intra-aortic balloon pump. Intracoronary imaging with IVUS before and after angioplasty was performed. A 3.5 by 38 millimeter DES was placed from ostial left main to LAD after predilatation with a 3 by 30 millimeter NC balloon. And you see after the standing a suboptimal result with a proximal L6 subocclusion, which was relatively good tolerated by the patient. We've done a proximal optimization technique of the left main LAD stent, L6 rewiring and predilatation, and you can see the ANSI result. The next step was a TN small protrusion standing of L6. A 3.5 by 18 millimeter DES was positioned into the L6 with minimal protrusion in the LAD, while an uninflated 3 by 3.5 millimeter by 20 millimeter NC balloon was placed in the LAD at the bifurcation. This was controlled in two orthogonal views. We proceeded with TN small protrusion standing. We've done a final pod with an excellent angiographic results. And here you can see the steps for the TAP technique. A very important side, how to remedy incorrect stent placement in the course of the TAP standing. And my conclusion, primary angioplasty for unprotected left main disease in patients with STEMI is a high-risk emergency intervention and should be performed in centers with mechanical circulatory support, intensive care unit, and cardiosurgical backup within the center. The T and small protrusion standing is a feasible and safe technique for both bailout side branch standing during provisional and planned double standing intervention in patients with bifurcation lesions with or without ACS, including the unprotected left main disease. The main advantages of the method are the compatibility with a 6 French guide catheter, the complete coverage of the side branch ostium, and the facilitation of the final kissing balloon inflation. Thank you very much.
So, thanks a lot for this really interesting and very important lecture concerning treatment of bifurcation in the settings of acute coronary syndromes. It was really very well illustrated. Questions, comments? Ioannis?
Well, it was a nice presentation. The two cases were fantastic. Cases very interesting. Well, my two main issues when we deal with bifurcations in the setting of acute coronary syndrome is what are you doing with the thrombus? Sometimes you sort of snowplow the thrombus formation from one branch to the other. And maybe in this kind of situations, maybe the best scenario is to leave the side branch alone and don't treat it alone. Don't even treat it if it's not really worth it. The other issue is how do you assess the hemodynamic significance of the side branch? And we know there's a discrepancy in the FFR measurements in the acute coronary syndrome as regards to the microvascular resistance and also in comparison to the stable coronary artery disease. So these are the two main issues, what to do with the thrombus and what to do also with the hemodynamic significance of the side branch. So, but other than that, this was very informative and the two cases were really good.
That is really a very important comment because what we know from practice, depending, usually there is a big thrombus burden. And we should not forget that this thrombus burden is treatable with pharmacological treatment. And this is something that we should keep in mind. And very often we leave some thrombus and not very good, let's say, angiographical results with some shifting of the thrombus into the side branches. And finally, after a good medical treatment, antiplatelet therapy and anticoagulation, when you do a follow-up, you have more clear idea what is needed and what is the result. And very often this thrombus disappeared, and it seems that further actions were unnecessary in this case. So this is something that we should all keep in mind while doing with acute coronary syndromes and a big thrombus burden. Thanks a lot. So we are moving.
I have a question.
Yeah.
Sorry, short question. Thank you for the excellent presentation. And my question is about the double antiplatelet therapy. When you have such a complex situation with the bifurcation and complex technique in terms of acute coronary syndrome, do you recommend a prolonged DAPT or you stick to the guidelines?
It's a very good question. Pharmacotherapy is a very important aspect in the setting of bifurcation lesion treatment in the setting of acute coronary syndromes. You're asking about the dower of the antiplatelet treatment.
Prolongation.
It depends on many different aspects, on many different factors. In the case of provisional standing, I should give my patient 12 months, and if we have left main bifurcation, which was treated with a two-stent strategy, we should make considerations to lengthen the dower of that therapy.
Lifelong, or you perform some imaging to prove the result?
Scores which can help us to calculate the risk of stent thrombosis and to give us answers about the length of antiplatelet therapy dower. It depends on bleeding risk. If we have a patient with ulcer in duodenum, it's difficult to give after a two-stent strategy of left main lifelong antiplatelets. It's aspects that should be cautiously investigated and individualized for every patient.
Thank you.
Thanks. Now we are going on with the program, and this is a very interesting presentation, which is very important in bifurcations. challenging wiring, and I would invite Dr. Pirot and thank him for coming and being with us, Zoltan.
Thank you very much. It's my pleasure and honor to be in this prestigious Congress and talk to you about the bifurcation with challenging wiring. Why? What do we call a difficult bifurcation? I think if the angle between the side and the main branches is unfavorable, meaning more than 90 degrees, or if there's complexity within the bifurcation, it is long or calcified, aneurysmatic or thrombotic, for that matter, or if there is tortuosity or a lesion just proximal to the bifurcation of our interest, or if there's a severe osteal lesion of the side branch. These make especially the wiring of the side branch difficult. Of course, you may have difficulties in wiring the main branch, but the majority of my talk will pertain to side branch wiring. As a general rule, of course, we have to review the angiogram and plan. We should have plan A, plan B, and plan C, how to proceed. And we should choose the best views, at least two orthogonal views, in which the angle is biggest between the side and the main branches, and there's no foreshortening. We can clearly see where we enter. This is especially true for special devices that I'm going to discuss with you in this talk. And of course, we should have bailout plans as to what happens if we cannot proceed with what we were planning first. As a general rule, we should have guidings with good backup support. So EBU and AL guiding catheters are preferred to Judkins type of guiding catheters. But I think Ivo will like this comment. This is not a contraindication to transradial approach. I think if the complexity of the bifurcation is not that high, as for example the case of George requiring 8 French guiding catheters, of course a transradial approach, especially in a man of large stature, is absolutely acceptable. So you can use 7 French guiding catheters or guiding catheters without sheathless guides can be used. So the first question is, why actually bother wiring both branches, especially if you're talking about provisional T-stenting, which is the default strategy in the majority of cases? Well, of course, wiring the side branch will protect it from closure should it occlude due to plaque shift and or the main branch stent struts protruding into it. And the jail branch side branch wire will facilitate the rewiring of the side branch after main branch stenting, because it widens the angle, as we well know, between the main and the side branches, and it also acts as a marker for the side branch ostium. But again, we should exert caution when removing the jail wire, because it may just make the guiding catheter jump into the coronary and cause dissection. The most important technique that we use is individualizing our wire. Of course, we can use a single bend, a short tip or a long tip, or a wide, smooth bend. But most of the time, my preferred technique is double bend, respecting the anatomy. So this is why we should pay attention to the anatomy of the bifurcation. And we usually start with workhorse wires that we are most familiar with and apply a torquer for being able to guide the wire into the side branch of interest. As a general rule, there is no standard guide wire shaping that will work for every single bifurcation. So we should use your personal experience and creativity, but again, caution should be exerted with applying too much of creativity, because the more complex the tip, the curve of the tip, the more difficult it is going to be to maneuver once you are in the side branch. So this is probably a very well-known cartoon, the coup de volant maneuver. If you cannot enter directly into the branch of interest, you will go beyond the ostium of the side branch with a small curve, and then while drawing the wire back and making a clockwise or counterclockwise turn, you are able to enter the vessel of interest. In very special cases, like in the ones that are depicted in this right panel, you may use a long U-shape or a reverse wiring or reverse hook technique. Sometimes a hook of up to 5 centimeters is needed. But again, even if you're able to enter the side branch with retracting your wire, it's going to be exceedingly difficult to manipulate it and place it and track it down so that you have enough support to place microcatheters or balloons across. So this is sometimes very, very challenging. Should your workhorse wire not work and your tip shaping not work, you have to escalate your wire. Of course, you may find the cyan blue, or for my selection, the Pilot 50s, generally the first wire that I use. You may go and change this wire to Fielder FC or Fielder XT or cyan black. But again, I should remind you that changing projections is of utmost importance, because sometimes you're convinced that from the two-dimensional image you have at hand, you're certain that you're entering the right way, and still, if you change your projection, you will see that you're actually way off base. And this is especially important if you go to special devices. The balloon backstop technique is a niche technique. It actually means that if you cannot enter the side branch at any rate, you just place a balloon over the main branch wire and you inflate it in order to occlude the main branch and help the wire just jump into the side branch. This, of course, is limited by the ischemia that is created by ballooning it, so patients will not tolerate, especially if it's a very proximal part of the vessel. And of course, you may cause dissections in the main branch, which may extend to the side branch also, making things even worse. But this should be, of course, listed there. If there is a tight lesion proximal to our bifurcation, of course, a predilatation with a small-sized balloon at low pressures will help, because it just creates some space for advancing the side branch wire with this complex bending beyond this tight lesion. But again, we should exert caution not to dilate too much, not to create dissections there, because again, this is going to make things worse rather than better. As a rule of thumb, of course, we have to remember the importance of proximal optimization, because this holds true for after stenting and rewiring the side branch. POT is not only important because, as we were shown, of course, the size of the stent should be chosen according to the size of the distal main branch. But of course, that means that it's, especially if the side branch is large enough, that will be grossly underexpanded in the proximal part of the vessel. And if you try to rewire before you pot the stent, you may go under the struts. And of course, if you are able to track a balloon over this wire, you may even crush the stent. So, of course, pot is important not only to make the geometry perfect, but also it facilitates rewiring of the side branch. And as a rule of thumb, we always use the jailed wire there as a marker, so we never remove the jailed wire before we actually rewire the side branch. Okay, these are the simple techniques: shaping, reshaping, re-reshaping, checking, and so forth. If it fails, what's next? Of course, you have microcatheters on the table. You can use your workhorse microcatheters because they increase the wire and tip control. And of course, they make it easier for you and quicker to exchange the wire for either another wire or for the same wire to be reshaped and tried again. But there are special microcatheters, and I'm not sure we are all familiar with those. There are curved, steerable, or dual lumen microcatheters. Like this one, the Venture microcatheter is a 0.014-inch wire compatible microcatheter with a deflectable tip. The tip can be oriented and deflected up to 90 degrees and well controlled by a knob on a proximal handle of the microcatheter. And thereafter, the microcatheter tip can be directed into the main side branch, and the guide wire can be advanced into it. But it needs a very good device-specific experience. And of course, the tip deflection can cause dissection in an unpredictable way. And in this case, it is extremely important to check from different projections whether we are entering the true lumen of the side branch. And of course, it is unsuitable for relatively small-sized vessels because you need some space for the tip to be deflected. On a similar idea, there is a steered deflecting tip guide wire. It's a 0.014-inch guide wire with a mechanism similar to the Venture microcatheter. It has a flexible radio platinum alloy coil on the distal tip, and this distal tip is deflectable bidirectionally by a proximal handle mechanism of the guide wire. But again, of course, it comes at a price. It is less trackable than workhorse guide wires, and of course the tip deflection may cause vessel injury, because if it's deflected or advanced into the vessel wall, of course you may dissect the main artery. Dual lumen microcatheters have been discussed quite considerably because we have CTO experts here. They have a rapid exchange and over-the-wire lumen. The over-the-wire lumen with the side exit at 6 to 10 millimeters from the microcatheter tip. We use the rapid exchange lumen for the main vessel and the over-the-wire lumen to advance the guide wire into the side branch. So we usually place the microcatheter over the main vessel wire so that the exit site of the OTV lumen is at the side branch ostium, and we try to advance the guide wire through this OTW lumen. And it can be of any shape, so it allows even a hairpin bend on this wire. But again, the orientation of this microcatheter is not fully controlled, so you may not be certain where exactly the exit site of the OTW lumen is. So it sometimes requires quite a bit of manipulation, and of course, again, checking from different angulations. There's a variety of microcatheters with dual lumens available on the market, and I think we should not use them all. We should familiarize ourselves with one or two of those and use them in the majority of our cases, not only CTO cases, but also cases with difficult wiring in bifurcations. And this will be of major help. This is something very important. And as a last resort, we can use rotablation if there is a very critical and heavily calcified lesion just proximal to the bifurcation. In this case, we can use a small burr of 1.25 or 1.5 millimeters and just rotablate the critical lesion just proximal to the bifurcation in order to make it possible to advance any specific equipment like the Venture microcatheter in this case, and a specifically tip-shaped guide wire. But again, of course, it runs the risk of side branch closure if there's dissection and if it extends to the side branch. One word of caution is that not only do we have to be able to wire all important branches, but sometimes it matters how and where we wire them. So for example, in the DK crush technique, I'm sure most of you will be familiar with that, requires that the side branch stent is rewired in the mid-strut. That gives us the best outcome, as opposed to provisional T-stenting, in which the distal strut should be the one that we actually pass the wire through, because that will give us the best coverage of the side branch ostium, as shown by this elegant 3D OCT images. Just one last word, we have to be very thoughtful, and this was already alluded to, because if the bifurcation is not that complex, we should think that the side branch does not subtend so much of myocardium, and functional evaluation comes into play, and as shown more than 15 years ago by Professor Koo and colleagues in side branch osteostenosis after main bench stenting. A QCA diameter stenosis of less than 75 actually never resulted in a functional significant stenosis of the side branch, and only about a third or a fourth of the side branch lesions above that significance and geographic significance did have an FFR of less than 0.75. And what is important is that, which is not shown in this slide, is that these results actually were maintained. So at 6 months there was no penalty to pay, and there was no FFR late loss. So actually, functional imaging, especially in stable coronary artery disease, is important, and we can actually downgrade the complexity of our therapy to complex-looking bifurcation by evaluating the side branch. So, ladies and gentlemen, in order to conclude, I would like to state that, of course, important side branches should be wired, and there is a variety of devices available for this. And if we should remember that if it's difficult to wire the side branch, it will be even more difficult to recross. So we should consider treating this side branch first. Thank you very much.
Thanks. Excellent presentation. Comments from the panel, from the audience? Dr. Iakovou?
Well, I enjoyed the presentation. As always, it was excellent, very, very well structured. So I couldn't add more to this, but maybe to stress something that Dr. Piroth also mentioned, of course, but you have to be really really careful when you take out the jail wire. It's not only the dissection that you might provoke, it's also longitudinal deformation, because when you deal with the hardware that you implant, and in such a way, maybe you end up doing something really bad. And from time to time, you will end up, if you IVUS this stents immediately or later, when they come back, the stents thrombosed or stenosed, then you end up seeing the things that you provoke by the deep seating of the catheter due to retraction of the jail wire. But this is something that we should always pay attention. Thank you.
Thank you.
Thank you. Professor Sianos has a
George?
question.
So one thing that sometimes, very rarely, happens is that consider that you applied everything and you failed, and you have a branch that mainly due to angulation of it, to access it in advance. There are cases that we are standing over, occluding the branch, and then it's easier to reaccess an occluded branch through a stent when the angulation is corrected. So we have some cases like that, and I always do it, so we cannot insist for hours in a side branch, or we cannot abandon the intervention. So consider that correcting the angulation, even with a high risk of losing the branch and reaccessing, it might be also a solution.
Thank you. Cannot agree more. And I of course agree with the former remark, and it's especially true for very proximal, like left main stenting. When you have the guiding catheter very close to the just freshly implanted stent, it can be deformed quite considerably with the guiding catheter. So it's, in these cases, we always disengage the guiding catheter from the ostium of the coronary, so that the guiding catheter does not touch the stent and will not distort it. And of course, there are other scenarios. For example, if you have the wire in the side branch, you stent the main branch and the side branch occludes and you cannot re-enter. You may, as a last resort, choose to place a small balloon on jailed wire and try to open it somewhat, crushing the main stent in order to establish flow in the side branch. And thereafter, you may think what you can do about it. Of course, these are, I mean, very, very desperate cases. But of course, you have to apply your creativity, as in all bifurcations. So usually, we cannot answer questions, which is the best strategy. Of course, there is not one best strategy in all bifurcations, because there is such a variety of those, determined by the size of the side branch, the disease that you have in the side branch or the main branch, the importance of the side branch for that particular patient, and so forth and so on.
Recently, just a comment, we had the chance finally to work with the super cross catheters, and our experience is very positive. Of course, it's an issue, but I think it's a nice device and very useful, because very easily you can address the side branch, especially if, for example, the vessel is very big, and this is it saves a lot of time, and it gives you the opportunity to use a curve of the wire which is you need distally to the vessel, because it is sometimes you have to enter into the vessel, and after that you have to do some work. Thanks a lot. It was a very great session. Thanks to all of you. Ioannis.
Thank you.
It was a pleasure to see you, and thanks for participating.